Welcome to the deep dive. Today we're looking beyond the usual muscle strains and joint pain. We're diving into something maybe less obvious, how repetitive actions, things we do every day at work, or even for fun, can actually affect your blood vessels.
That's right. We're drawing on some key chapters from Rutherford's vascular surgery and endovascular therapy to explore these vascular conditions. It's fascinating stuff, really, because it's not the typical musculoskeletal injury we think of with repetitive strain.
Exactly. We usually think, carpal tunnel, tennis elbow.
Right. Muscles, tendons, nerves, but arteries and veins. They're vulnerable too, surprisingly, right from your fingertips up to your shoulder.
And the impact isn't trivial, is it? I was looking at some older data, I think from the U.S. Bureau of Labor Statistics around 2015.
Oh, yeah.
It showed that people actually took more time off work for these kinds of repetitive motion injuries compared to other types.
That's a huge point. It points to a major societal issue: disability, cost, lost productivity. It's significant.
So it really matters not just for individuals, but for the economy, too.
Absolutely.
Yeah.
And it's not just, heavy manual labor jobs. It could be musicians, factory workers, even office workers potentially.
Okay, so our mission for this deep dive is to really unpack how these repeated activities and exposures can hit your arteries and veins in the upper body.
Yeah, what that might mean for you, whatever your job or hobby.
All right, let's get into it. First up, hand-arm vibration syndrome, HAVS. Sounds like a classic manual labor issue.
It is, and it's got quite a history. We've known about something like this for over a century. Back in 1911, Lariga in Italy described dead finger in miners.
Dead finger.
Yeah, that cold, white feeling. Then Hamilton in 1918 linked it to pneumatic drills, stone cutters. Later, researchers like Taylor, Pelmier, Ash really nailed it down as a distinct condition.
So it went by different names before HAVS, dead finger, Raynaud of occupational origin, things like that.
Exactly. The shift to hand-arm vibration syndrome, or HAVS, is important, though,
Why is that?
because it acknowledges that the problem isn't just confined to the fingers. The vibration can affect the whole hand, maybe even the arm. It's broader.
Got it. So the main thing people notice is that Raynaud phenomenon.
That's the core symptom, yes. Triggered by cold, usually, after prolonged use of vibrating tools.
Can you describe what that's like for someone who hasn't experienced it?
Sure. It typically starts at the fingertips. They'll turn white, blanching, due to the blood vessels spasming shut.
Just the tips?
Initially, yeah. But it can spread to the whole finger. These attacks, they usually last about an hour or so.
And then what?
Then the blood flow rushes back in. That's called reactive hyperemia. The fingers turn bright red, and it can actually be quite painful, throbbing even.
Ouch. Sounds unpleasant.
It is. And if you're exposed to cold for a long time during an attack, the fingers might even turn bluish-black. That's cyanosis.
That sounds serious. Does it lead to permanent damage often?
Thankfully, progression to things like skin ulcers or gangrene is pretty rare, maybe around 1% of cases, but the pain and numbness can be really debilitating.
Okay. What kind of tools are we talking about here? The main culprits.
Well, the classic ones are things like pneumatic hammers, drills, grinders, chainsaws,
Yeah.
basically any handheld tool that vibrates significantly.
But it could be other situations too.
Absolutely any job or activity with prolonged hand-arm vibration exposure is a potential risk.
Is there a dose-response relationship? Like more vibration equals more risk?
It seems so. Research suggests a pretty linear link between the total vibration dose, considering both intensity and duration over years, and the chances of getting HAVS and how bad it gets. It's cumulative.
Right. Makes sense.
Yeah.
But what's actually happening inside the blood vessels? What's the mechanism?
That's the tricky part, and it's probably multifactorial. We don't know the exact mechanism down to the last molecule,
But we have some ideas.
we do. The vibration itself seems to cause direct physical damage to the endothelium, that delicate inner lining of the arteries.
Okay.
This damage can then trigger platelets to stick together locally, which is, the first step towards forming a clot and blocking the artery.
So physical damage plus clotting.
Right. And there's also evidence suggesting the sympathetic nervous system gets involved. It becomes hyperactive.
The fight-or-flight system.
Sort of, yeah. It controls blood vessel constriction. And the vibration seems to make the finger arteries hyperresponsive to cold, which helps explain the blanching.
Wow. So it's a mix of direct damage and the body systems overreacting.
Pretty much. It's complex.
Are some people more likely to get HAVS than others? Risk factors?
Definitely. Smoking is a big one. It consistently correlates with getting symptoms and worse symptoms.
Okay. Smoking's bad. Anything else?
Some studies suggest lower levels of serotonin might play a role, and certain genetic variations, like in the HTR1B gene, could increase susceptibility.
Interesting. Genetics, too.
Yeah. And on a biochemical level, vibration triggers the release of endothelin-1, which is a potent vasoconstrictor. It mirrors blood vessels.
Double whammy.
Kind of. And at the same time, it seems to impair the release of nitric oxide, which normally helps relax blood vessels. So yeah, it pushes things towards constriction.
Okay, so if someone thinks they might have this, how does a doctor figure it out? How's it diagnosed?
Well, first step is always the history. Talking about vibrating tool use, those classic Raynaud symptoms, that's key.
Then what? Tests.
Yes. A cold provocation test is common. You cool the hands and measure how long it takes for finger temperature to return to normal. Slow recovery suggests a problem.
Makes sense. What about seeing inside the vessels?
You can use non-invasive tests like Doppler ultrasound or duplex scanning. These measure blood pressure in the fingers. A significant drop compared to the arm pressure points towards a blockage in the digital arteries.
And for more complex cases?
Arteriography might be used. That's where they inject dye and take x-rays. Give a very detailed picture, shows blockages or narrowing.
Is that where you see that corkscrew pattern you mentioned?
Exactly. Barker and Hines describe that characteristic look of the small vessels in advanced cases. And MRI is sometimes used too. It can help differentiate HAVS from another condition called hypothalamic syndrome.
Right, we'll get to that. Any key study findings?
Yeah, a Northwestern University study on workers using chippers found quite a few had reduced finger blood pressure. Some had confirmed digital artery occlusions on arteriograms. Interestingly, they also found the palmar arch, that network of arteries in the palm, was often incomplete, even in hands without symptoms. And lots of these workers had Raynaud's and abnormal cold responses.
So the underlying plumbing might already be a bit different in some people.
Potentially, yeah.
Okay, treatment. What can be done? And maybe more importantly, prevention.
Treatment first. The absolute #1 thing, if possible, is to stop or significantly reduce exposure to the vibration. DIOH recommends this. That's crucial.
Stop the source. Makes sense.
Quit smoking, definitely. If symptoms are bad, calcium channel blockers like nifedipine can help relax the blood vessels.
Medication.
In very severe cases, like with digital gangrene, intravenous drugs called prostanoids might be tried. Surgery, like cutting sympathetic nerves, is rarely done these days.
So mostly conservative management.
Mostly. Because prevention is really where it's at.
How do you prevent it?
Anti-vibration gloves can help dampen the vibration reaching the hands and keep them warm. But the biggest thing is limiting exposure.
How?
Through workplace standards. There are U.S. and international standards that limit the dose, how intense the vibration is, and the duration, how long you're exposed each day. Adhering to those is key.
So regulations and protective gear.
Exactly. And there's also a classification system, the Stockholm Workshop Scale, that helps grade the severity, which guides management.
Okay, that's HAVS. Let's shift gears slightly, but stay with manual labor. Hypocene syndrome, HHS, what's that about?
Right, so HHS is another one linked to repetitive trauma, but is very specific to the ulnar artery where it crosses the hypothenar eminence.
The fleshy part of the palm below the little finger?
That's the spot. The ulnar artery, along with the nerve, runs through Guyon's canal at the wrist, but then the artery becomes quite superficial right over that mound.
Ah, so it's exposed.
Very much
Okay.
so. It's only covered by skin, a bit of fat, and a small muscle. It lies right over the hook of the hamate bone there.
So if you repeatedly hit that part of your hand,
Exactly. Repetitive pushing, pounding, twisting motions using the heel of the hand, that compresses the artery against the bone underneath.
hence hammer syndrome, what kind of jobs put people at risk?
Mechanics using their palm like a mallet, factory workers striking things, carpenters, masons, anyone who habitually uses that part of their hand as a tool, basically.
Has this one also been known for a while?
It has. Von Rosen reported a case in 1934, and there are even descriptions going back to the 1700s. But it was Kahn and colleagues in 1970 who really clarified the mechanism and gave it the name HHS.
Is it common or maybe underdiagnosed?
Probably under-recognized, yeah. The exact incidence isn't known. One study on mechanics found, I think, 14% had evidence of ulnar artery occlusion, but many didn't have severe symptoms.
So they might not even know they have it.
Right. But if you look at patients referred to specialized centers for hand ischemia, HHS accounts for maybe 1 to 1.6% of cases. So it's out there.
What actually happens to the artery itself? What kind of damage?
It varies. You can get a thrombotic occlusion, a blood clot blocking it completely, or you can get an aneurysm, a bulge in the artery wall. Sometimes both.
How does the trauma cause that?
The repeated impact can cause spasm and damage to the inner lining, the intima. That attracts platelets, leading to clot formation. Damage to the middle layer, the media, weakens the wall, potentially causing an aneurysm.
And the aneurysm itself can cause problems.
Yes, because clots can form inside the aneurysm, and then bits can break off and travel downstream distal embolization, blocking smaller arteries in the fingers.
Nasty. You mentioned something earlier about potential underlying issues making people more susceptible.
Yes, that's a really interesting finding from Ferris and his group. They looked at arteries removed during surgery for HHS and found changes suggesting fibromuscular dysplasia, FMD.
Which is?
It's basically an underlying abnormality in the structure of the artery wall. What was really striking was that in many patients who had arteriograms of both hands, the ulnar artery on the asymptomatic side often showed similar abnormalities.
Wow, so maybe the trauma is hitting an artery that's already a bit weaker.
That seems to be the idea. The repetitive trauma acts on a predisposed vessel. It might be a two-hit process.
Okay, so how does HHS show up? What are the symptoms? Is it like HAVS?
It often presents with Raynaud phenomenon, yes, but with some key differences. HHS is much more common in men, particularly smokers, with that clear history of repetitive hand trauma.
Okay.
And the symptoms are usually asymmetrical, often just the dominant hand. While you get the pallor, white, and cyanosis, blue, that hyperemic redness phase afterwards is often missing or less pronounced.
And which fingers are affected?
Typically the ulnar 3, little, ring, and middle finger. The thumb is usually spared because its blood supply is different.
What would a doctor look for on examination?
Cooler mottled fingers, maybe small ischemic ulcers on the tips in severe cases. You might see a callus over the hypothenar eminence from the impacts.
Right, a telltale sign.
And the Allen test is often positive, showing poor flow through the ulnar artery. Occasionally, if there's an aneurysm, you might actually feel a pulsatile lump there.
And imaging, how do you confirm it? Still arteriography.
Duplex ultrasound, CT, MRI can all be useful, but yeah, invasive arteriography is still considered the gold standard.
Why is that?
It just gives the clearest picture of the lesion. Is it spasm, aneurysm, occlusion? Where exactly is it? It also shows the palmar arch anatomy and any collateral vessels, which is important for planning treatment. And again, you might see that corkscrew pattern in the digital arteries from emboli.
And you'd look further up the arm, too.
Always important to check the proximal arteries to rule out other sources of clots.
So, treatment for HHS. What are the options?
It's a bit controversial because it's relatively rare, so there aren't huge comparison trials. But the good news is that most patients seem to improve with non-surgical measures. Stop smoking, absolutely critical. Protect the hand, avoid cold, avoid further trauma to the palm. Medications like calcium channel blockers and antiplatelet drugs are often used. If there's actual tissue death, anticoagulation might be needed.
When would surgery be considered?
Generally for severe persistent ischemia that's really affecting the fingers, or if there's a significant aneurysm causing symptoms or emboli.
What kind of surgery?
If collateral flow is good, sometimes just ligating, tying off the damaged segment works. More often, it involves resecting the bad bit and either repairing it directly or putting in a vein graft, usually from a leg, to bridge the gap. Sometimes an arterial graft is used.
And the results?
Case series generally report good symptom improvement and decent long-term results after surgery.
Okay, let's move on from direct trauma and vibration to problems from specific occupational exposures. What else should we know about?
Well, there's a condition called occupational acroosteolysis. It's quite specific.
Acroosteolysis. Sounds like bone loss.
It is. Resorption of the bone in the tips of the fingers. It was first really noted in workers exposed to polyvinyl chloride PVC.
Huh. And that affects blood vessels, too.
Yes, many of these workers also had hand ischemia symptoms, Raynaud's like vasospasm. Angiography showed digital artery damage, narrowings, blockages, and some unusual extra blood vessel growth near the bone loss. Clubbing of the fingers can happen, too.
How's it treated?
Unfortunately, treatment is mainly supportive managing symptoms.
So, chemical exposure affecting bone and blood vessels. What else?
Electrical burns are a big one, especially high-voltage injuries.
Over 1,000 volts.
Yeah. The current can cause widespread tissue destruction, including severe damage to arteries, necrosis, clots, bleeding, potentially leading to gangrene. The hand and upper limb are often involved.
What does the artery damage look like?
Angiograms can show occlusions, particularly in the ulnar and digital arteries, clots in the radial artery. You can also get spasm initially, and later on, aneurysms can form due to the wall damage.
And treatment?
Complex. Depends heavily on the extent of injury to bone, muscle, nerves as well. Sometimes vascular reconstruction with bypass grafts is possible to try and salvage the limb.
A devastating injury.
It can be. Then there are issues from extreme thermal injuries, particularly chronic cold exposure.
Like working in cold environments.
Exactly. Slaughterhouses, fisheries, canneries. People can develop vasomotor problems, basically Raynaud syndrome.
Is there much research on this?
A bit limited. One study on Swedish military trainees found prolonged cold exposure led to reduced sensation, but interestingly, not changes in finger blood pressure. Those symptoms like cold intolerance persisted for years.
Any specific risk factors identified?
Things like alternating hot and cold exposure, wearing occlusive plastic gloves in the cold, and just long-term cold exposure seem to increase risk. Again, treatment is mainly supportive.
Okay, so chemical, electrical, thermal exposures. Let's switch tracks completely now to athletes. We hear about orthopedic injuries all the time, but what about vascular problems?
Yeah, it's a really interesting field. Athletes involved in repetitive, strenuous upper body movements are definitely susceptible to arterial injuries causing ischemia.
Where do these injuries happen?
Pretty much anywhere from the subclavian artery near the collarbone, right down to the digital arteries in the fingers. There are specific syndromes recognized at the thoracic outlet, the quadrilateral space in the shoulder, around the humeral head, and in the hand.
Do we know how common these are?
Exact numbers are hard to come by. A lot of the reported cases involve elite athletes, especially baseball players.
Pitchers and catchers?
Them particularly, yes. But it's also seen in karate, volleyball, handball, even things like frisbee, lacrosse, golf, weightlifting, swimming. It's a broader range than you might think.
Let's start with the hand then. Hand ischemia in athletes. How does that happen?
Two main ways, generally. Either direct injury to the finger arteries or emboli coming from a problem higher up in the arm.
Direct injury from impact.
Yes, blunt force in any sport could potentially do it. But you see direct digital artery trauma more often in sports like handball, martial arts, and definitely baseball catchers.
Handball?
Yeah, studies, particularly on basketball players, show pretty high rates of hand and finger artery injuries correlating with playing time. Beach volleyball players, too, playing time and female gender seem to be risk factors there.
And catchers, we mentioned them with HHS potentially, but also just general ischemia.
Right. The repetitive impact from catching fastballs predisposes them to chronic hand ischemia, Raynaud symptoms, sometimes worse in the off-season. Studies have shown reduced perfusion and occlusions in catchers' fingers.
Any specific injury mechanism in pitchers' hands?
Yeah, there's a specific one described involving compression of a digital artery by something called the Cleland ligament during hyperextension of a finger joint in the throwing motion.
Wow, quite specific. How are these treated in athletes?
Depends on the injury. Acute trauma might get conservative treatment initially, maybe dextrin infusion, pain control. Medical therapy could involve pentoxifylline or calcium channel blockers.
Anything newer?
Botox injections have been tried for vasospasm, with some reported success in case series, improving pain and healing ulcers.
And surgery.
For severe ongoing symptoms, surgery might be needed. Digital periarterial sympathectomy has been done for handball players. For that Cleland ligament compression in pitchers, surgically releasing the ligament can work well.
And prevention.
Padded gloves are key, especially for catchers, to try and absorb some of that impact.
Okay, moving up the arm. Quadrilateral space syndrome. Where is that space again?
It's in the back of the shoulder, bordered by the teres minor muscle superiorly, the humerus laterally, teres major inferiorly, and the long head of the triceps medially.
And what runs through it?
The posterior humeral circumflex artery and the axillary nerve.
And the syndrome is the compression of those.
Yes, described initially by Cahill and Palmer. In overhead athletes, pitchers, volleyball players, that cocked arm position, abducted and externally rotated, can compress the artery.
What does chronic compression do?
It can lead to aneurysm formation in the posterior humeral circumflex artery or occlusion. And again, clots from an aneurysm can embolize down to the hand.
Is there a classification for this?
Yes, the Mayo Clinic group proposed vascular QSS, VQSS, and neurogenic QSS, NQSS.
What's the difference?
VQSS is what we just described, repetitive trauma to the artery in overhead athletes causing thrombosis, aneurysm, emboli. NQSS is more about fixed compression, maybe from fibrous bands or muscle hypertrophy, often due to repetitive microtrauma. You might see NQSS more in recreational athletes like swimmers or workers with overhead tasks.
And the symptoms differ.
Yes, NQSS symptoms are typically more nerve-related, muscle atrophy, weakness, tingling, a vague deep shoulder ache.
How are they treated differently?
For VQSS with emboli, maybe thrombolytics first, but usually surgery is needed to deal with the aneurysm, often involving ligation, tying off, of the posterior humeral circumflex artery. You have to be careful to preserve other blood supply to the humeral head.
Right, avoid a vascular necrosis.
Exactly. Post-op anticoagulation might be used. For NQSS, you might start conservative anti-inflammatories, PT, activity modification. But often, surgical decompression releasing bands, neurolysis is needed for athletes to get back to full activity.
Okay, next up, humeral head compression of the axillary artery. That just sounds even more direct.
It is. Lord and Rosati first reported this. It's literally the head of the humerus bone pressing down on the axillary artery during those extreme overhead abducted, externally rotated motions.
Like in throwing or striking.
Precisely. Ultrasound studies have actually documented blood flow being impeded in that position. The bone directly pinches the artery.
What symptoms does that cause?
Arm fatigue, loss of velocity or power, maybe finger numbness, Raynaud's, even those little cutaneous emboli of the fingers. So performance decline plus vascular signs.
How's it diagnosed?
Clinical suspicion plus imaging. Duplex ultrasound and arteriography, crucially done both at rest and in that provocative arm position to demonstrate the compression.
Treatment.
If it's just compression without actual artery damage, sometimes modifying the motion is enough. If not, or if there's narrowing, surgery might involve a saphenous vein patch angioplasty to widen the artery.
And if the artery is more seriously damaged?
Then resection of the damaged part with a saphenous vein bypass graft might be necessary. Mobilizing the artery to free it up can also help. Results are generally good, with athletes often returning to competition after rehab.
Finally, arterial thoracic outlet syndrome, or TOS, in athletes. We hear more about nerve or vein TOS usually.
True, neurogenic and venous TOS are more common overall, but arterial TOS can happen in athletes with those extreme overhead motions, pitchers, swimmers, butterfly, weightlifters, rowers.
Where does the compression happen in TOS?
Several potential spots in that outlet between the collarbone and first rib, between the scalene muscles, in the costoclavicular space, or under the pec minor muscle.
What causes it in athletes? Extra ribs sometimes.
Can be underlying bony issues like a cervical rib or an anomalous first rib. But in athletes, often it's muscle hypertrophy. The muscles just get bigger from training and start compressing the artery.
And chronic compression leads to?
Same kind of problems. Thromboembolism, clots forming and traveling, occlusive disease, narrowing blockage, or aneurysm formation in the subclavian artery.
And there have been some high-profile cases.
Yes, Toulis reported an axillary artery clot in a pitcher back in '72. Struckel and Garrick described TOS in pitchers. And Fields reported that famous case of a major league pitcher having a stroke from subclavian artery thrombosis due to TOS. Really serious potential consequences.
Symptoms sound familiar again. Arm fatigue, loss of velocity, numbness, Raynaud's.
Exactly. Very similar to humeral head compression often. Diagnosis can be tricky. Needs careful orthopedic assessment too. Duplex and Doppel scans in provocative positions are key. Arteriography with positional views is usually definitive.
And treatment for arterial TOS.
Depends on the cause. If it's muscle tendon compression, releasing that might be enough. If there's a problematic rib, it needs to be removed, often via a transaxillary approach.
What if the artery needs fixing?
Subclavian artery reconstruction often needs combined incisions above and below the collarbone. A saphenous vein graft is usually preferred. Long-term patency of the grafts is generally good, but data on return to elite competition is a bit more limited than for some other procedures. The goal is always to decompress and restore normal flow.
Wow. Well, this has certainly been a deep dive. It's really quite striking how these repetitive motions and exposures, things we might do at work or for sport, can have such significant impacts on our upper body's vascular health.
Absolutely. I think the main takeaway is just that awareness. Whether it's vibration, impact, or extreme repetitive motion, these seemingly small things, repeated often enough, can really add up and affect arteries and veins in ways we might not expect.
It really highlights the need for awareness and, where possible, prevention, doesn't it?
Yeah, definitely. Things like using the right protective gear, like anti-vibration gloves, ensuring proper technique in sports, maybe modifying tasks if possible. These can make a real difference.
It might seem like small stuff, but potentially prevents bigger problems down the road.
Exactly. And while, some of these specific syndromes are rare, just understanding that a link can exist between your activities and unusual symptoms like pain, numbness, or color changes in your hands or arms is important.
So if you experience something like that, especially with a history of these kinds of activities, it's worth mentioning to your doctor.
For sure. Don't just dismiss it. Early diagnosis and management are always better.
So maybe a final thought for everyone listening. Take a moment to consider the repetitive actions in your own life, work or play, Could they be having subtle effects you haven't thought about? And are there maybe small adjustments you could make for your long-term vascular well-being? Something to think about. Thanks for joining us on this deep dive.